Here is Atlantic staff writer Ed Yong.
Hello, I'm Ed Yong, a staff writer at The Atlantic, and I'm joined by Dr. Anthony Fauci. He's the director of the National Institute of Allergy and Infectious Diseases, and he is the chief medical advisor to President Biden. Dr. Fauci, it's good to talk with you again.
Thank you very much. It's really good to be with you today. Thanks an awful lot.
In the last time we spoke, you had a different boss. Neither of us was vaccinated. Things have looked better since then, so much so that in May, you said to the Washington Post that if 70% of adults were vaccinated by the fall, then we're going to get out of the epidemic stage and much more into the control stage. Well, it's now the fall, around 65% of adults are vaccinated, but things don't seem very controlled. Hospitals are still struggling, death rates are high. What went wrong?
Well, I'm not so sure anything went wrong. I know something came onto the scene that made everything really very different. And Ed, I'm sure you know what that is, but I'll mention it. It's the Delta variant. So I don't think anything went wrong in the sense of what we were trying to do is to get as many people vaccinated as we possibly can. Well, you know, we don't have 70% of the population fully vaccinated. We have about 55% of the total population fully vaccinated. We still need to go a ways. We know now, you know, and I think most of the viewers may not realize that we have about 70 million people in this country who still are not vaccinated. That is particularly problematic when you do that in the context of a Delta variant, which is really substantially more transmissible than what we were dealing with at the time that you and I had that discussion. So again, we always can do better. So I don't think one should say, well, there's nothing we could have done better. But I don't think you could say something went wrong. I think what we have is a formidable virus, which we've realized right from the very beginning. And these kinds of surges that we're seeing regarding Delta are not isolated to the United States. I mean, the entire world virtually has been hit by this. So now that we are in this situation, how do we address it? We do know that the vaccines do work really quite well against Delta. There are breakthrough infections that I'm sure we'll get a chance to talk about, but that's because no vaccine is 100% effective. What the vaccines have done quite well thus far, we'll have to see about the durability of that protection, but what they've done quite well thus far is to prevent people from getting to the hospital and ultimately dying, because if you look, even with the breakthrough infections, which naturally will occur when you don't have a 100% effective vaccine, that the deaths overwhelmingly are among people who are unvaccinated. So bottom line, Ed, at least for this part of the conversation, is that we have within our grasp, within our power, the ability to have a major impact on what we're seeing now with the numbers of infections. We've been well over 100,000 infections for quite a while now, and hospitalizations were up and deaths were up. Right now, it looks like we're turning the corner a bit with a diminution in the number of cases and a diminution in the number of hospitalizations. Deaths are still going up, but that's usually a lagging indicator of what's going on in the community.
And Tony, I don't disagree that the vaccines have been extraordinarily effective, perhaps more so than anyone could have hoped for this time last year. That said, many of the folks who I've spoke to who work in public health and other disciplines have suggested that the US has put too many eggs into the vaccine basket, and in some cases traded them off against other interventions that are important. The move away from indoor masking in the spring as one example, the continuing insufficiencies in testing as another. Would you agree with that? Do you think that we have overemphasized vaccines at the expense of other strategies?
No, well, I think what you said is partially true, Ed. It's a little bit more complicated. I think it's not one or the other. I think we've placed a lot of emphasis on what is known historically and in real time now as a very, very high impact pharmacologic intervention in the form of a vaccine. I mean, there's no doubt about that. I don't think we have overemphasized it. Regarding at the expense of others, well, you know, when you get to the situation with masking, that has really been a very complicated issue, and it's understandable how people might have that impression of what's gone on. You're right. At the time that the CDC made that change in the mask guidance was at the time just when Delta was starting to really, really go up. I mean, I think obviously now, if they were to look back at that and see about that decision, they would say, given the context of what Delta has done, likely that should not have been the policy back then. But they quickly went back, and I know this can be confusing, and in fairness to them, they quickly went back when we saw that Delta was a really quite a formidable foe here. If you want to make it a metaphor, it is a foe and we're at war with it, that in fact we do still need to have masks, even if you're vaccinated, when you're an indoor congregated setting in which you're in a location where there's a lot of dynamics of spread. And quite frankly, as we got into the summer, that essentially, with very few exceptions, became the entire country. When you look at the orange and red on the map, you know, it essentially became an orange and then an almost totally red map. So surely masking, it would have been nice if we, not nice, that's not the right word. It would have been preferable had that been done earlier. But I think the testing thing, you do have a point. We have really, and I've said this, Ed, if you go back over the records of the many things that we've said in discussions, I've always said, right even before this administration, that we should be flooding the system with easily attainable at-home testing so people can get a good feel for themselves, their families, their workplace, about who is infected and who is not. Just the fact that we have very highly effective and safe vaccines should not make us move away from intensity of testing, because testing is going to be very important, particularly when you have a virus in which you will have breakthrough infections. I mean, I think people need to understand, and maybe that's kind of an unfortunate terminology that's used, because it essentially gives it a connotation that the vaccine has failed. Well, if the vaccine prevents you from getting sick, prevents you from losing work time, prevents you from getting to the hospital, and prevents you from dying, that's a really, really successful vaccine, even if you have a breakthrough infection. But if you do have a breakthrough infection, as we know now from several epidemiological studies, that you can still, with this particular virus, it wasn't that way with the Alpha virus, but it certainly is that way with the Delta virus, that even though you are vaccinated and that you yourself may not get symptoms at all, or if so, only mild symptoms, you are still capable of transmitting that infection to someone else. And that's the reason why, among other reasons, not the only reason, but among other reasons, why we really need to do a lot of testing and make it very, very available. I mean, I have conversations with our British colleagues who are really quite generous in their sharing of their experience with us, and me particular. I deal on a regular basis with Chris Whitty and Patrick Valence from the UK, the health authorities there, and they are very, very much tuned into making testing really widely available to virtually anybody on their own, at home or wherever, at a very, very easy accessibility, price-wise and convenience-wise.
Do you think the US can get to that point?
I hope so, Ed. I think we can. I think we can, because I think, as you were alluding to in your question, and the undertone of it is quite correct of what you were getting to, is that we can't be unidimensional in our approach to this outbreak, which is, as I said, a cunning foe here.
A cunning foe indeed. And so, Tony, on that, I wanted to ask about your position on boosters. You seem to have been quite bullish about about using them, and you've defended the administration's decision to talk about widespread availability before the FDA had a chance to weigh in. How are you feeling about boosters now? What is your stance on the role that they should play in the pandemic going forward?
Okay. Well, first of all, Ed, let me put it in context, and I will directly answer your question.
Sure.
And I believe that people need to understand that at the time we're giving boosters here and in other countries of wealth, it is important to make sure that we do more than just pay attention to the developing world, the low and middle income countries, that we are very aggressive and put a lot of resources into making sure that as we're getting boosters and as we're trying to primarily vaccinate our people, that we give enough resources, enough doses, enough capability of making vaccines to the developing world. So I believe we can do both, and we shouldn't do our boost at the expense of getting vaccines to the developing world. And in fact, the United States thus far, and we are going to be doing more, Ed, thus far have done a lot, with now 1.1 billion commitment of doses already given over 160, I believe, to over 100 countries. So we're doing it, and we're going to do more, and we should do more. Having said that, I've made it clear, Ed, that my opinion has always been that I believe that a third shot booster for a 2-dose mRNA should ultimately and will ultimately be the proper complete regimen, as opposed to the proper and complete regimen is 2 doses, and then the third dose is a luxury, as it were, a luxury for a failing vaccine. The vaccine is very successful. The durability of it is something that's subject of considerable discussion and sometimes debate. The one point that I will make, it's somewhat at variance, and I believe we need to be transparent when we have opinions that are at variance. I supported and continue to support what the FDA did on the basis of the information they had and on the advice of their advisory committee. I support what the CDC has done. And I think that Dr. Walensky made a very good, informed, and I thought courageous choice in modifying a bit. She took the advice of the committee under advisement, and she made a modification of it. The way I feel as a physician and as a scientist and a public health person, that I think it is not entirely correct to make this very strong gap and dichotomy between waning immunity that gets you waning for protection against hospitalization and death, and waning immunity against infection, mild to moderate disease. It is an assumption that is okay to get infected and to get mild and moderate disease as long as you don't wind up in the hospital and die. And I have to be open and honest. I reject that. I think we should be preventing people from getting sick from COVID, even if they don't wind up in the hospital. And somebody can say, well, wait a minute, you're talking from both sides. No, you can support something that's done given the current information. And I think given the current information about waning immunity for hospitalization and waning immunity and looking at the safety issues that relate to the context of young people, young men particularly, who might be at a risk for the very rare occurrence of the myocarditis, I take that all into context, which is the reason why I still thoroughly support what the CDC has done. However, I believe that ultimately, and I want to underscore that, and I do that slowly, Ed, because as you know, as well as I, every time I say something, something gets plucked out of it and it will be out of context. I say that ultimately, I believe that the optimal regimen for the vaccine, for the mRNAs, is going to include that third booster shot.
And Tony, do you feel that that's been communicated, the idea that the plan was always going to be 3 doses? Because I sort of feel that it hasn't been, which sort of leads to where we are now, where 2 is considered full and 3rd feels like an extra, and in some places, some people would argue unnecessarily so.
Well, Ed, I'm glad that you asked the question the way you asked it, because I know you're a smart interviewer, and you asked that. But we did not always know that a 3rd dose would likely be an important part of the proper complete regimen. You recall, we went through it together, that in the early trials, we started off with a prime, followed by a boost, 3 weeks for Pfizer, 4 weeks for Moderna. The results were so strikingly good, both in the animal model and in the phase 1, phase 2 trial of the induction of a high level of one of the parameters of immunity, which is neutralizing antibody, that given the emergent nature that we were having a lot of people in this country and in the world dying, that we didn't have the luxury to say, wait a minute, you know what we're going to do? We're going to try multiple different doses and make sure we get it just right. We were in an emergency situation. So we went with what was really good, a prime and a boost that already the track record has shown you that it has saved millions of lives. If you look at the difference between unvaccinated people and vaccinated people with regard to hospitalizations and deaths, the vaccines have been overwhelmingly successful. What we did not fully appreciate, and there was no way of knowing it, what the durability of that would be. Now, all right, we know people, and I'm an immunologist, and I know what other immunologists say, which is true, that the antibody level going down doesn't necessarily mean that you're not protected, because you have memory B cells, you have T cells, but the clinical phenomenon is the thing that you need to pay attention to. And that's what we were seeing a strong suggestion of already in the United States, but a profound indication of this in Israel, that over time, protection against hospitalization was going down, starting off with the elderly and then even occurring across age groups. And without a doubt, the protection against clinically recognizable disease was going down. We did not know that during the clinical trials. What we did know, that those prime and a second shot were clearly saving millions of lives. But we were not aware at the time, or as the word you used, we always knew. We didn't always knew. What we're starting to see now and fully appreciate is that it is likely for a real complete regimen that you would need at least a 3rd dose. Now, the question is going to be, does that mean we have to boost people every single year? We don't know that now. So when you and I have an interview 6 months, a year, 2 years from now, Ed, we'll revisit that. We don't know.
Okay.
What I hope is going to happen is that this is going to give to the human immune system of vaccinated people that degree of maturation of response that will really give much more durability to it.
And Tony, another thing that you said that I wanted to revisit, you talked about the tension between needing to provide first doses to much of the world versus extra doses to people who've already been vaccinated here. A lot of other scientists and health experts have seen that those two things as in opposition to each other, such that focusing on an incremental gain for immunity for people who've already been vaccinated here, works against the goal of broadly immunizing the rest of the world. Now, you've said that we can have both of those two things together, and I was hoping you could just justify that. Like, why do you believe that to be the case? And if that is the case, then why haven't we made better progress with global vaccine equity to this date?
Well, I think the latter we need to do. So, I mean, anybody who knows anything about how I feel about global equity and global accessibility need go no further than the HIV experience with PEPFAR. So, my feelings and my track record on that are available for anybody to examine. So, I do feel that we do have that obligation. The issue of 1 dose versus 2 dose, if you have enough, that only becomes an issue when you really do have a scarcity of doses. But when you have enough doses, you should go with the full regimen at the time, which was 1 dose followed by a boost. What experience has shown us that although there is some protection, and there's no doubt about it, you can't deny it, with 1 dose, it is not adequate. And we have seen, particularly in the context of variants, people who have been vaccinated with a single dose do not have nearly as much or even adequate protection. They have some protection, but if you look at when all of the studies, and you're very well aware of them, Ed, I know because you've commented on them in your writings, that if you look at studies comparing 1 dose versus 2 dose in multiple different parameters of infection, of getting infected with variants, of clinical disease, of hospitalization, without a doubt, although you do get some protection with 1 dose, it is not nearly as good as 2 doses. And that's the reason why we wanted to make sure, to the best of our ability, we get people vaccinated with both doses.
Okay. We talked about pandemics and preparing for them back in 2018, well before COVID was a thing. You and many others told me about these cycles of panic and neglect, where a crisis hits, everyone pays attention, investments flow, and then inevitably things lapse, and our willingness to do what is necessary to prepare against future pandemics also slips. Now we are still in the middle of this, but what do you think? Do you think that we're destined to repeat that cycle? What can the US be doing right now to avert tomorrow's pandemics?
Well, I have been in the unfortunate situation, Ed, of having lived through multiple cycles of the phenomenon that you are just now describing, of semi-panic and promising that we'll not let this kind of thing happen again. And we've been through HIV, and we've been through pandemic flu, and we've been through Zika, and we've been through Ebola, and now we have a historic outbreak with COVID-19. My feeling, Ed, is that I really do sincerely hope, having been through all of that myself personally, that we will not allow what we've been through over the last 20 months to slip from corporate memory, which means we have to, and we are, starting right now, not only responding to the current pandemic, but preparing for the next pandemic. Not saying, which we've essentially done in the past, get through the problem now because we got to focus on what's going on now. And as soon as it's over, then we're going to worry about preparing for the next. It's kind of like you're working hard to get this under control, and then you go, whew, it's over. And then all of a sudden you turn your attention to the next problem that is a real and present problem, as opposed to a real and present danger. I think what we've learned now, Ed, is that given the way the human-animal interface and the jumping of viruses from one species to another, what we've seen with Ebola and what we've seen with HIV, SARS-1, MERS, we've got to be prepared from multiple standpoints. So a pandemic preparedness is not unidimensional. It's everything from global cooperation to communication to surveillance, both at the animal level and the human level, to have a basic and fundamental clinical research endeavor where you're able to do things like take a pathogen, in this case a virus, recognize it, and in time frame that is unimaginable, get vaccines ready to go into people, not only ready to go, but produced enough to get into people. That's what we're talking about now. You know, OSTP came out with a pandemic plan that they announced to the tune of needing about $65 billion to do that. So we're not talking about pandemic preparedness for a couple of billion. We're talking about tens of billions of dollars that will be needed to get us to where we are. So bottom line, Ed, I really do hope that when we get through this, which we will, we don't then start focusing and concentrating on another problem that takes our mind off this extraordinarily difficult period that we've all lived through.
I hope so too, Tony. Well, thank you so much for taking the time to talk to us today. I look forward to speaking to you again, although hopefully this time next year we'll be able to talk about something else. Thank you so much for your time.
Thank you very much, Ed. It's always a pleasure to be with you.
Yeah, you too.